There you go. Okay, great. So thanks everyone for attending this noon lunch and learn here. We're very, very excited. We've got Dr. Megan Borkham, who's here to talk to us about exercise in our kidney care clinic patients. Dr. Borkham is one of our advanced trainees doing a home dialysis fellowship. She's already a nephrologist doing this additional training. And in addition to that, she's been wearing many hats these days at BC Renal, and one of which she's developed a very keen interest and expertise in this area, really, of exercise and health maintenance across the spectrum of chronic kidney disease. So we're very, very lucky to have her for the session today. A few housekeeping items just before we get started. Although we're all joining together virtually in this webinar, I think it's always good for us to reflect on where it is we're coming from across the province. Myself, over here in Surrey, I work on the shared and unceded territories of the Katzie, Semiahmoo, Kwantlen, and some other Coast Salish peoples. And I think it's good for all of us to reflect a little bit about where it is we're all coming from across this beautiful province. Another item that I would like people to mention is in this webinar type format, just to keep things manageable in terms of sound. You can't ask questions directly. We can't unmute you, but we still would encourage it. If you have any questions, if you could just type them into the little Q&A box, I'll kind of keep track of those, and we'll hold those for when there's an opportunity for Dr. Borkham to address them. So please do get your questions in, and we'll address it that way. Otherwise, without any further ado, I'd like to turn it over to Dr. Borkham for this talk we've all very much been looking forward to.
Thank you for the kind introduction. I know I just gave a talk last week on exercise in dialysis patients. I promise you this is a completely different talk. Just reused, I think, one of the slides. I hope to give you a bit of a how to perpetuate the exercises medicine initiative. So this initiative encourages physicians and other healthcare providers to include physical activity when designing treatment plans with patients. And the belief is that physical activity promotes optimal health and is integral for prevention and treatment of many medical conditions, not just CKD. So I hope that through this talk, you can see the merits of this philosophy and how to implement it in your practice. So I have no financial disclosures, unfortunately, and I'm not an exercise professional or exercise scientist. I just have a really keen interest in the topic. And I do generally try my very best to practice what I preach. In terms of learning points, the first half of this talk will be a bit sciencey. I've tried to keep the statistics and that to a minimum on a Friday afternoon. The second half will be mainly sort of practical, how to, and less of the numbers and more of the real world implementation. But we're going to review the recent literature on the therapeutic role of exercise. We'll look at current recommendations for exercise and physical activity in CKD patients specifically. So again, the evidence is different for CKD than it is for dialysis. We'll discuss the role of the kidney healthcare team. We'll look at common barriers to implementing exercise programs for people with CKD. And I'll give some practical examples of how to prescribe exercise and how to engage your patients meaningfully. So we'll get going with some definitions. Physical activity is any bodily movement produced by the skeletal muscle that requires energy expenditure. So basically anything that gets you moving. There's various domains, for example, domestic, such as gardening and housework, and occupational, such as transportation and climbing stairs in an office. Exercise, though, is specific and purposeful. It's a form of physical activity which is planned, structured, repetitive, and intended to improve or maintain physical fitness. Examples include cycling, or something we do try to encourage on beautiful sunny days, hiking. On the other hand, cardiorespiratory fitness is defined as the ability of the circulatory and respiratory systems to supply oxygen during sustained physical activity and exercise. And it's usually expressed as maximal oxygen uptake, or VO2 max, during maximal exercise testing. There are various ways to measure the VO2 max, most accurately being in a lab with specialized equipment, but you can calculate it without equipment, and many of the newer smartwatches also calculate VO2 max. And some patients are interested in tracking this number as a measure of fitness. Cardiorespiratory fitness is, however, a very important consideration as it's a strong predictor of mortality, and low fitness gives a particularly high risk of death compared to other common risk factors such as diabetes, high cholesterol, or hypertension. And in patients with CKD, cardiorespiratory fitness has borne out as an independent predictor of mortality, regardless of the patient's eGFR. So my only recycled slide from last week, I will highlight some of the commonly used outcome measures in studies of exercise in CKD patients. I'll mention and refer to these. So just to let you know what they are, you can do the hand grip strength, which is a surrogate of upper arm strength, and you measure it using it as a with the dynamometer, which most dietitians have, and basically various ways for which the patient squeezes the device, and you can measure the hand grip strength. There's also the 6-minute walk test, where the patient walks as far as possible in 6 minutes, measuring the cumulative distance walked between 2 cones. And the cones are usually about 20 to 30 meters apart, depending how much space you have to do the test. There's the 30-second sit to stand test, where the patient sits in the middle of the chair with their hands crossed across their chest, crossed at the wrists, and they have to rise to a full standing position and then sit back down again as many times as possible in 30 seconds. There's also numerous generic and disease-specific symptoms and quality of life assessment tools. None have borne out as more superior to the other, but various forms have been used. Examples we're familiar with, of course, the ESAS. Lifestyle refers to a way of living that affects the risk of being seriously ill or dying early. Now, the majority of people with CKD, as we all have experienced, do not adhere to several of the recommended levels of lifestyle behaviors. This graph is accumulated from many different countries. So 2/3 of adults with CKD in the US don't meet the recommended physical activity levels, and they're sedentary. More than 3/4 of people with CKD are overweight or obese, and nearly half to 3/4 of people with CKD do not consume a healthy diet. And this depends on the definition of a healthy diet or a recommended diet that you're using. Encouragingly, though, we are doing something right. Non-smoking ranged between 71 to 92% from CKD cohorts in Europe, North America, and Japan. And among individuals with CKD in the United States, reports of non-smoking are similar to that of the general population, so approximately 86% of the population. Encouragingly, nearly all individuals with CKD, and again, this is from worldwide data, 93% meet alcohol recommendations. At baseline, patients with CKD generally engage in low levels of physical activity, and this decreases with progression of the kidney disease. You can see the red arrow showing a stepwise increase in the black box of inactivity in Figure 1. Inactivity then reaches a nadir once the patient reaches hemodialysis, and this nadir is particularly prominent in elderly patients. In the second figure, you can see that it's estimated that approximately 65% of waking time, once the GFR is below 60, is spent sedentary in CKD populations, with only 10% of waking time being physically active. That's food for thought. Similarly, in this trial, which was published in CJSON at the end of 2021, 386 Canadian frailty observation and interventions trial participants, CANFIT, with an eGFR of less than 30 were included. 162 of these patients progressed to dialysis. Patients with advanced CKD experienced progressive decline, as we said, in physical activity and function, and transition to dialysis was associated with an even more accelerated decline in physical function, as measured by the time sit to stand chair test and with self-reported physical activity scales. Now, to me, this reinforces that exercise in dialysis is relevant, but proactively targeting physical activity and exercise modifications earlier on in the patient's chronic kidney journey to mitigate this decline is equally important. And also from a practical perspective, a patient starting on PD needs to have the upper arm strength to lift a bag, to be able to do their manual exchanges or to set up their cycler. So it does have implications, and it should be done throughout the chronic kidney disease journey. So why does this happen? CKD results in, among other factors, protein energy wasting, sarcopenia, frailty, and disability, and is associated with elevated levels of all-cause and cardiovascular mortality. Unsurprisingly, this downward spiral of inactivity is common in CKD and impacts the quality of life of this patient population. As such, intervening through the means of physical activity and exercise may provide an opportunity for improving function as well as physiology, and in the short term, improve quality of life, but can also possibly benefit patient outcomes through modifying their disease progression, both directly and indirectly. And mortality risk can also be affected, as well as reducing healthcare costs. So what is the evidence of the role of exercise for outcomes relevant to CKD? So from an interesting historical perspective, rest was once considered one of the treatment options for CKD, especially for patients with nephrotic syndrome. There were case reports from the 90s even suggesting that exercise may worsen the level of proteinuria and renal function. However, over time, it became clear that exercise-induced proteinuria was temporary and reversible without renal function loss. So exercise therapy for CKD patients has gradually gained popularity, and more so in recent times. While the benefits in the general population are clear, research has focused on understanding whether similar benefits are noted in CKD specifically. Since we like to practice evidence-based medicine, I will now go through as quickly as possible the evidence base for the benefits of exercise in non-dialysis CKD, so you can have informed discussions with your patients. So yes, exercise does help blood pressure in CKD. There are 5 high-quality systematic reviews with meta-analyses of randomized control trials on the effects of exercise on blood pressure. In the most recent, by Thompson and colleagues, a meta-analysis of 8 studies were conducted with the inclusion of 335 non-dialysis CKD patients. Though all studies were at high risk of bias, they found significant reductions in systolic blood pressure after 12 to 16 weeks of approximately 5 millimeters of mercury, and after 24 to 36 weeks of exercise of approximately 11 millimeters of mercury. Despite some limitations, for example, not controlling for medication changes, there is sufficient evidence to warrant the current recommendations that exercise can improve blood pressure. Although some of this effect may be attributable to positive body weight changes that occur with increased exercise and physical activity, these results are encouraging. It's less clear whether or not exercise affects CKD progression. There is a lot of research being done on the topic currently, but as the evidence stands, 2 of the studies reported that aerobic exercise programs show no discernible effects on eGFR. However, another meta-analysis reported, with the inclusion of 11 randomized controlled trials totaling over 350 patients, with an average of 35 weeks of aerobic exercise, eGFR was increased by over 2.2 mils per minute per meter squared. But the data is limited. Many of the studies have been low or moderate quality in methods, and considering the confounding effect of muscle mass-related changes on eGFR, these things have not been considered. So we can view these results cautiously. There is, however, a scientific basis to suggest that there should be a plausible direct benefit in mortality reductions. Studies have found reductions in inflammatory cytokines after only 12 weeks of resistance exercise interventions. And it's thought that exercise reduces sympathetic nervous activity as well as oxidative stress. But obviously more trials would be needed to prove this. Importantly, though, with all of that said, there is no reason to believe that the risks of physical activity participation outweigh the potential benefits in this population. It's also unclear if exercise in CKD patients reduces mortality and hospitalization. Much of the research about the direct effect on the outcome measure of mortality in non-dialysis CKD is derived from observational studies, so low quality, using retrospective analysis and self-reported physical activity levels, which have innate scientific limitations. Regarding mortality, this meta-analysis I've shown here concluded that the use of self-management interventions, and exercise was included as self-management intervention, showed no significant difference in the risk of all-cause mortality. But there is a growing body of evidence in the dialysis population that there's a link between physical activity and mortality, as well as hospitalization. So again, more studies are required in the non-dialysis CKD population. Interestingly, there is good evidence for muscle health, physical function, and physical capacity. There's a talk about a muscle-kidney crosstalk. So we all know about the heart and kidney crosstalk. So there's a muscle-kidney crosstalk. where contracting muscles stimulate the production of muscle-secreted factors, which can in turn affect growth and stimulate regeneration in the damaged kidney and promote better function through various mechanisms. Looking at exercise to improve muscle mass, evidence is mixed with a mixture of high and low risk of bias. However, the effects of physical activity and exercise on muscle strength have all been positive. So 3 randomized controlled trials report an increase in quadriceps strength, which is a surrogate of lower limb muscle strength, and 1 an increase in hand grip strength using a hand grip dynamometer. 2 meta-analyses looking at the effect of exercise on physical capacity reported a positive effect of exercise, including improvement in the 6-minute walk test and the number of bicep curl repetitions the participants could do. 4 meta-analyses concluded a beneficial, clinically relevant effect of an exercise intervention, which was extended on the VO2 peak, so the VO2 max, which, as I said, is a surrogate of cardiorespiratory fitness in non-dialysis CKD patients. This is important because, as I mentioned, in patients with CKD, cardiorespiratory fitness is an independent predictor of mortality, regardless of eGFR. This is one of the few randomized controlled trials of evidence in CKD, which was published in KI Reports in 2019. They compared the effects of 2 exercise training programs on physical performance in 151 non-dialysis CKD stage 3 to 5 patients. Mean age was 66 years. Patients were randomized to endurance training in combination with either balance or strength training. The 2 exercise modalities required 150 minutes of total training time a week, comprising of 60 minutes a week of endurance training and 90 minutes a week of either strength or balance exercises at moderate intensity. Program duration was 12 months. So the strength group median total training time was 100 minutes, so less than the prescribed 150 minutes, and the balance group was 118 minutes a week. Adherence rates were 62% in the strength group and 68% in the balance group. The training resulted in a highly significant improvement in endurance, assessed by the 6-minute walk test, muscle strength measured with quadriceps strength, and balance measured as functional reach in both groups. Importantly, for me, this is evidence that marked benefits can be observed in CKD patients with volumes of activity well below the prescribed 150 minutes a week and with not 100% adherence. So this is encouraging. In terms of health-related quality of life, there's no doubt in general populations that exercise improves the quality of life. A significant amount of research has sought to determine whether exercise is able to increase health-related quality of life in non-dialysis CKD patients. Looking at currently available literature, 3 systematic reviews have shown that increasing levels of physical activity or undertaking of regular exercise programs can indeed increase quality of life. The most recent of these is shown here in 2020, published in a Nephrology. They assessed the findings of 6 recent randomized controlled trials, and they found a significant positive effect of an exercise intervention, which was predominantly aerobic based, so mainly cardio, on quality of life measures. In April 2021, the UK Kidney Association published the first ever clinical practice guidelines for exercise and lifestyle for those living with a kidney condition. Guidelines summarize the latest evidence and include recommendations for physical activity and exercise. The GRADE framework, where 1A evidence is the strongest and 2D the weakest, was used to evaluate the quality of evidence and the guide clinical practice points. You can see the benefits of exercise listed here. So improved blood pressure, physical function, physical capacity, and health-related quality of life nicely summarize the proven evidence to support exercise in CKD that we've just discussed. There is less quality evidence to suggest it helps in symptoms of depression. You can see the last point, it's graded 2C. So multiple barriers do exist though, both for staff and patients, and they're extensively cited in literature in the field, particularly poor physical conditions and symptoms associated with the patient's disease and treatment. For example, reduced walking ability, fatigue, pain, and shortness of breath and weakness. as well as existing comorbidities. Importantly, a lack of awareness of exercise guidelines was indicated as a barrier to exercise by both patients and healthcare providers. Other barriers identified include a lack of accessibility to exercise professionals and a lack of motivation. These barriers can be summarized into three broad themes, so knowledge, skills, and expectations, human, material, and logistical resources, as well as social dynamics of the unit. Disease acceptance, self-care, perceived benefits of exercise, and increasing energy and strength are all important motivators for exercise. However, encouragement appears to be the greatest motivation to adhere to physical activity. An individualized prescription by an exercise professional adapted to the patient's physical function, CKD level, and disease treatment plays an important role. However, it's not the be-all and end-all. Possible solutions to these limitations also include advocating for skilled exercise professionals in the kidney care team, encouraging peer support networks, and also becoming familiar with the evidence. Internationally, there's been large movements in the field of renal rehab. So with the increase in the elderly population and our aging CKD cohort, there's an increased rate of frailty in CKD patients in the world. Frailty is closely associated with high mortality and lower quality of life. Recognizing an urgent need to clarify the effects of exercise interventions in CKD, the Japanese Society for Renal Rehabilitation, so a society specifically focused on renal rehabilitation, was established all the way back in 2011. Renal rehabilitation itself is defined by the World Health Organization as a long-term comprehensive program consisting of exercise therapy, diet and fluid management, drug therapy, education, as well as psychological support to alleviate the physical and mental effects of kidney disease and dialysis therapy, prolong life expectancy, and improve psychosocial and occupational circumstances. So in summary, restoring function. However, renal rehabilitation in Canada is limited. Now, if you compare this to other organ rehabilitation, so pulmonary rehab or cardiac rehab that all of our post-MI patients attend, you can see there's a stark discord in the amount of in the availability of renal rehabilitation programs compared to these other programs. So current programs are focused on developing evidence-based guidelines to support the delivery of rehabilitation programs to patients living with CKD. There's currently a study underway specifically on renal rehab in Manitoba. And certainly in the UK, the NHS, despite all their flaws, has rolled out numerous renal rehab programs across the country. However, once again, a big problem is the lack of reimbursement from government and health insurance companies, which precludes its approach in many settings. So bringing things back to the KCC setting, where could exercise professionals fit into the structure of the KCC setting? So falls are a leading cause of disability in older populations, with direct healthcare costs estimated to be $2.2 billion annually in Canada. The top 4 reasons for our patients falling are loss of balance, leg weakness, slips or trips, and these are all preventable causes. This is why emphasis is on exercise professionals to empower our patients to build leg strength, perform balance exercises, know the environment, and take their time when ambulating. Other important roles of exercise professionals specific for the CKD arena include pain management. We know a lot of our patients struggle with chronic pain, weight management, implementing other self-management strategies such as acupressure, and encouraging patients to follow home exercise programs and providing consultation and guidance on how to implement a home exercise program. So there's lots of ways we could use exercise professionals in our setting. However, unfortunately, exercise professionals are hard to come by. So the onus is upon us to at least have a conversation with patients. Sometimes people do struggle to initiate the conversation. So at the outset, it would be good to request permission to talk about exercise and physical activity with your patient, and then follow up by asking patients about exercise rather than prescriptively telling them. And this would show that individualization and that you're helping support them to make their own decisions, slightly as such that more meaningful and realistic changes would occur. So open-ended questions that are useful to build the discussion would be, what exercises are you doing at the moment? A lot of our patients struggle to keep active. How about you? How have you been managing with your physical activity? Or tell me about your current exercise regime. It's a good way to start, and it gives the patient lots of room to reply. The next question would be from patients is, how much exercise should we be doing and at what intensity? So KDIGO and the World Health Organization recommend that patients with CKD should engage in moderate physical activity 5 times a week for at least 30 minutes and strength or resistance training 2 times a week. This guideline is extrapolated from general population data based on the assumption that the relative risk of inactivity and the effect of the intervention is similar in patients with CKD and in the general population. And while achieving these guidelines may not always be feasible in patients with CKD, at least initially, any increase, as we mentioned earlier, in the amount of daily physical activity while reducing sedentary time is likely to have health benefits. Prescribing an individual exercise program for patients with CKD should include frequency, intensity, duration of physical activity, and type of exercise, so endurance training, strength, flexibility, or balance. Regarding intensity specifically, the American College of Sports Medicine recommends exercising at moderate intensity at minimum, which equates to exercising at 60 to 75% of maximal heart rate for improvement in cardiorespiratory fitness. However, a lot of our patients, I don't think, would know what their maximal heart rate should be or would be out of touch with these calculations. So I find the easiest and most common way to gauge moderate exercise intensity, and this is cited in lots of discussion groups on the topic, is to use the sing-talk test. So patients must exercise at a level where they can talk during exercise, but would expect shortness of breath when trying to sing during exercise. So what exercises can we start with and suggest to our patients who are starting on their fitness journey? Low impact exercise is a great place to start, but this also needs to be individualized. So regular walking could be sufficient aerobic activity for a severely deconditioned 75-year-old patient with renal disease, whereas a 30-year-old patient with mild kidney dysfunction may require jogging to reach the recommended exercise intensity. So accordingly, we should make some kind of assessment of cardiorespiratory fitness and muscle strength to identify appropriate targets of exercise intensity according to patients' fitness levels. We're not exercise scientists. They look at muscle strength by assessing quadriceps strength. We can use specialized equipment like dynamometers, which most of our dietitians have access to. But simply asking the patient what functional limitations they encounter most is helpful. For instance, a patient who indicates that they have difficulties in stair walking or standing up from a chair can use these activities as a target to start exercise training. Many patients also have exercise equipment, so for example, stationary bikes at home. They just need the motivation to start using them. They won't tell you that they have exercise equipment if you don't ask. Last week in clinic, I had a PD patient with one of these QB peddlers. She wasn't aware of the app, which shows you how to use the machine and how to best implement different tricks to avoid monotony. There's also group classes that you can participate in using the device, and these devices generally run between $200 and $250 from Costco. And the patient was quite delighted that she could also track her progress on the app. Looking at the behavior of exercise and lifestyle modifications, making habits stick is difficult. But exercise habits are sustained if they're built up over time. So starting small and building up gradually as fitness improves. Habits should be part of daily routine. So meaning trying to do these activities when you do other daily habits, like when making your morning coffee or tea, or when taking your medications. When you establish a habit, it becomes automatic and you'll see the results. Habits should be attractive. So while watching TV or listening to music, you can use your peddler or lift some small weights with multiple repetitions. And exercise becomes satisfying if you're tracking your progress towards achieving a goal. Even as simple as closing the exercise rings on your Apple Watch every day adds to the motivation. SMART is an acronym to remind you how to set a goal that maps out exactly what you need to include in goal setting. So goals should be specific, measurable, attainable, relevant, and time-bound. For example, as a start, I'd like to start using my bike twice a week for 5 to 10 minutes each time for the next 2 weeks. And this goal setting strategy can be applied to any area in health. I did show this in my talk as well. My research group collected relevant resources into a convenient one-page reference for patients to access and to find their most preferred online source of inspiration to work towards the target exercise prescription. I'm going to highlight some of these resources. I know you've been introduced to the Kidney Wellness Hub. So the Kidney Foundation of Canada conducted a survey with kidney patients, caregivers, and healthcare providers at the end of 2019, so just before COVID ramped up, to better understand the needs of the kidney community. Participants wanted greater access to online wellness tools and information, as well as the ability to connect online and feel part of an exercise community and have a trusted spot to engage with resource experts. So they created this really dynamic online repository of customized kidney wellness information to support kidney patients and caregivers. There's comprehensive wellness resources, including on-demand fitness classes, cooking, and dealing with body image and mental health issues. Another great site is the UK Kidney Beam project. This was born in June 2020, also when COVID was raging and face-to-face rehabilitation services were cancelled. The steering group, consisting of kidney health professionals, scientists, and patients, developed the initial content funded by Kidney Research UK, and membership is still free and includes live exercise classes and a 12-week renal rehab program. Exercises are appropriate for various levels of fitness, and they're led by physiotherapists and activity specialists, some of whom are living with or working with kidney disease. Kidney Beam also includes some community groups to help users connect with others who have the same lived experience, as well as common interests and goals. And you can also connect with your class instructors as well if you have any questions about the exercises. The GREX network, as a healthcare professional, I found to be very helpful. They're an international collaboration of doctors, scientists, and patients, and they do have resources for both patients and healthcare professionals. You can join as a member for free. They have regular webinars on useful topics in the field of exercise and disease. They're having a symposium at the upcoming ASN, and they frequently send emails and article updates. So I can encourage you to all become members. It takes 2 minutes. Then these strength training resources, also highlighted on our handout, developed by the Leicester Kidney Lifestyle Team, which is a group of quite active researchers and mainly exercise physiologists, developed these exercises with the UK Kidney Foundation to help start strength training at home. There's a mixture of flashcards and videos, as well as ready-made programs to try. There's also handy hints and tips videos patients can watch when starting off. And you can see that the exercises are aimed at beginners as well as more advanced and intermediate levels. There's a lot patients can try. This is a very busy slide, as you're not expected to read it, but it's an example of some simple full body home strengthening exercises we developed for our initiative, with a handy video demonstration by a voluntary kinesiologist. And all patients need are a TheraBand and a chair, and they can work all major muscle groups. A big problem with exercise is how to maintain motivation. And this can be sustained in various ways: offering patients support and encouragement, referring them to local exercise programs in the community, or showing them that simple, affordable tools such as TheraBands can facilitate home exercise sessions. Patients are motivated if they enjoy what they're doing, so making exercise a social event or having an online community of peers is very helpful, as well as gamification of exercise to keep them interested and engaged. Although we can't all have Pelotons or VR headsets, I think the social space is very important, especially for our older patients who have limited social activity and interaction. People never have time, but making exercise a routine and planning time for it helps. And certainly tracking progress towards achieving goals set, weight, fitness, etc., is very rewarding and motivating. I'd just like to share with you other self-management tools, which are attractive options for our patients who want to feel empowered. So these were provided by our kinesiology colleague in Alberta, and they offer patients self-management techniques such as acupressure for insomnia and boxed breathing for stress and anxiety before reaching for medications and adding to existing polypharmacy. And these are really good, simple tools which patients have found really helpful. So in an email I got from GREX this morning, just to show you a high level of interest on the topic, I got sent a list of 29 publications or posters that are going to be at the upcoming Kidney Week in Orlando next week. The exercise in CKD and exercise in dialysis field seems to be growing exponentially. Topics include developing a curriculum to train exercise and healthcare professionals to implement exercise programs in CKD, the effect of a 3-year lifestyle intervention on cardiac parameters in people with CKD, the sub-study of a randomized control trial, and then the question which I asked earlier, why can physical activity reduce end-stage renal disease or CKD? So I think there's a lot to come, and I think we will learn a lot more in the next few years about this topic. So my take-home messages on this Friday afternoon is that physical activity is important for all kidney patients, and it can improve quality of life. We all have goals, and we all want our patients to have goals, but any movement is good. And there are multiple helpful online resources that I would like to encourage you to share with your KCC patients. And certainly the best exercise is one which they enjoy and do regularly. And with that, I would like to offer my email address if anyone wants further information on the topic or to discuss a strategy to implement exercise in their KCC clinic. And thank you very much for your attention.
Thanks so much, Dr. Borgum. What another, as always, you've done a few of these in a row now, very, very comprehensive review of the subject, as well as some practical tips. So thank you. Excellent. Just a reminder to everybody, if you have any questions, please put them into the chat there. Otherwise, I'll maybe, oh, the person with the hand up is you. Oh, I was going to say, you can't really put your hand up, we can't unmute you, but you got your hand up. Megan, anyway.
I did.
That's
I didn't intend to do that. Sorry.
You raised your hand. The floor is yours. You're allowed to say something if you like. So I'll maybe start one of the questions just while people are putting them in the Q&A. So one thing that comes up often with a lot of our patients, especially with many other comorbidities and everything, is do we need to have them cleared before we do exercise? So I thought maybe just a little bit of a discussion of, are there groups of patients that we can just go straight to talking to this about versus groups that you might want to have the nephrologist or other people weigh in on? Maybe just some practical advice there for the teams.
Yeah, so certainly the list of exclusions is probably shorter than the one in dialysis patients. So I think anyone with an unstable cardiac illness or significant valve disease would need clearance before they participate in an exercise program, and certainly someone who's just had a cardiac event, so a myocardial infarction, there's generally a waiting period before they engage in physical activity. But I think if patients are reasonable and start, as is mentioned, with low impact, slow progress, again, which is where the exercise professional comes in, because patients with limitations, so for example, patients with amputations, they can give them ways to exercise that, they can exercise around these limitations. Specifically, exclusion factors, again, I don't think there are many. Acute medical illness or active cardiac issues, I think, would be the major things. And of course, if patients want to exercise outside without someone there. That might also be a problem, especially if they're older and more frail.
Yeah, I think that's excellent. I think that's good for everyone to hear. Of course, if you have questions, you can always ask the nephrologist, but I love the way that you put it, that the list of exclusion criteria is pretty small. And yeah, compared to, when you have someone actively on dialysis at the time, here we're talking about these are ambulatory patients, right? So that's excellent. Yeah.
And certainly in all the studies, the adverse events related to the exercise are fairly mild or insignificant. So
yeah, perfect. Great. There's just a couple comments, I think, about the slides being available, which we'll have a recording of this, but if people would like the actual slides for some things, I think maybe even I'll even add that little one pager you have. We can send that out afterwards through the committee. So yeah,
I can email that to you, the PDF.
Yeah, email it to Jan and I, and we'll make sure everybody gets a copy of that. That's fantastic.
I had a meeting with the Kidney Foundation people this morning, in fact, and they're quite keen for us to be using their portal and give them feedback. They're hoping to roll out more detailed interventions in the coming year, and they're quite enthusiastic about sort of wellness. And I think it's going to be a focus of their projects for next year. So I think there's good things to come.
Yeah, I'm glad you highlighted again the wellness hub, and we've had Heather on to speak to the group about it as well. It's just such a great source of, like you said, it's really about giving some actual practical tips to patients rather than just say go off now and exercise. And that wellness hub just has some great examples of things like this. So I'm glad that you've highlighted that, and I saw it was on your one pager with all the little QR codes and everything, which is fantastic. We're not getting a lot of other questions coming through here. I think, there's many things about sending these resources out, which we will definitely do. Otherwise, yeah, I think that was quite comprehensive. We'll wait maybe another minute or two to see if there are any other specific items that come up.
I think if patients appreciates also just being told that they can do it. I think people have a lot of misconceptions as well about what they can and can't do. So I think even just a little bit of encouragement in the clinical setting does go a long way.
Yeah, I really couldn't agree more. And I think also it kind of ties to that point of saying, most people don't need specific clearance. I think that's kind of come up in our world. We see the same thing sometimes in our dialysis units, right, where people need to be cleared to sit in a chair, where people need to be cleared to go out and do some walking or hiking. And I think, breaking that mindset a little bit. Of course, there's some patients who you'll want to do so, like you just said, but for others, just removing the barriers, or removing that concept of medicalizing it versus this is a wellness maintenance item, that people should participate in. Yeah, otherwise it may just be, because that was excellent and thorough. We're not having a lot of questions come through aside from just everybody wanting to have the resources you put together. So we'll make sure to do that. Otherwise, again, I just want to thank you again for such an excellent and thorough talk on such an important topic. It was really, really
Thank
great.
you. Thanks to everyone for attending.
Okay, thanks everyone, and we'll send
Have a
all
nice
the slides out
weekend.
to everyone.
Thank you. Bye.
Take care.